Now we're going to do a task shifting function. Typically, this will be another speaker, but our next speaker is going to appear online, and it's a pre-recorded speech from the Director of Child and Adolescent Mental Health Division in the WHO, the World Health Organization. Please join me in welcoming Dr. Chiara Savilli, who will share with us building systems for young people's mental health in settings affected by displacement.
Good morning. I'd like to thank WICAMHD for the opportunity to contribute to this event. I'll be talking about approaches to building systems for young people's mental health with a focus on settings affected by displacement. We are talking about nearly 50 million children displaced because of conflict, violence, or other crises, as per the 2023 estimates. And we know that children who experience forced migration are more likely to be exposed to a wide range of risks for their mental health, already in the period preceding migration, during migration travel, as well as during the post-migration and settlement. These adverse factors include poverty, violence, dissolution of community and family support networks, barrier to access to education and health services, stigma, exclusion, and poor caregiver mental health. Many children develop immediate psychological distress symptoms, such as specific fears, dependent behavior, prolonged crying, lack of interest in the environment, psychosomatic symptoms, aggressive behaviors. Some children recover. For others, stress and trauma can activate responses with mental health consequences that can last a lifetime. They are more likely to experience PTSD, anxiety, depressive disorders in the medium and long term. Children exposed to more severe stressors are robbed of their safety at multiple levels, with implications for attachment and resulting negative effects on children's social and emotional development, well-being, and mental health. So in brief, forced displacement is a global threat to mental health and well-being of children. Displacement erodes factors that protect children's mental health, such as their physical security, nurturing care, access to education. We also know that forced displacement exacerbates existing vulnerabilities. Children and adolescents with existing mental health conditions may experience increased symptoms, are vulnerable to violence and human rights abuses, and often lose access to mental health support and services. So it is therefore really important to ensure the implementation of a community-based approach to support the mental health of young people with the intentional inclusion of strategies targeted to reach children affected by displacement. The ultimate goal is ensuring enabling nurturing environment as well as access to promotion and protection of mental health. This approach involves actions at different levels, at the level of the society, the community, family, and the child, building on community knowledge and local resources to strengthen systems, and with the involvement of both lay and professional services and local communities. WHO has made available a number of tools that can help facilitate implementation of this community-based approach to supporting young people's mental health. I will not provide in-depth information here. However, these documents are available on the WHO website and are open access documents. In this slide, you see some description of the mental health and psychosocial support minimum service package. This is a tool that was developed to provide orientation and checklist of action to support stakeholders' coordination across sectors and planning and implementation of actions. And the focus here is really reducing suffering and improve the mental health and psychosocial well-being, particularly among populations affected by humanitarian crisis. This toolkit has a life course approach, and it does include children and young people. Another slide, a toolkit with specific focus on adolescents, and particularly adolescent mental health promotion, as well as prevention of mental health conditions and risk behaviors. This is a toolkit which is part of the WHO UNICEF Helping Adolescents Thrive initiative. It provides evidence-based strategies to promote and protect adolescent mental health, and it has 4 core strategies as pillars of the approach. The first is about implementation and enforcement of laws and policies. The second is about improving environments with particular focus on the schools, the digital spaces, and the community environments. The third strategy is about supporting caregivers in order for them to promote adolescent mental health. And lastly, is about building individual adolescents' skills and resources. The toolkit provides the evidence-based approaches as well as country implementation experiences and examples, with particular attention also to tailoring up the strategies to include and reach vulnerable populations. As part of the Helping Adolescents Thrive initiative, we have also a teacher guide and a related comic book that have been adapted and used by country stakeholders to integrate social and emotional learning within secondary school curricula. Besides social and emotional learning, there is also a range of low-intensity psychological interventions that can help improve access to evidence-based intervention for adolescents with mental health condition. So the approach in terms of delivering low intensity or scalable psychological intervention is really to deliver some evidence-based strategies in a way that can be delivered by non-specialist providers and can be scalable. Ease or early adolescent skills for emotion is one of these low-intensity psychological intervention. It targets specifically young adolescents with internalizing problems. And this is a brief group-based cognitive behavioral intervention. It has been tested in the context of different countries and has shown effectiveness in terms of reducing social emotional symptoms in adolescents and also reducing caregivers' psychological distress and inconsistent disciplinary parenting. There are also resources to facilitate self-help, stress management, as well as psychological first aid. Doing What Matters in Times of Stress is an illustrated guide to facilitate stress management and to help individuals cope with adversity. The guide aims really to equip people with practical skills to help cope with stress, and it can be used alone or with accompanying audio exercises. I Support My Friend is a tool for older children and adolescents to support their peers in distress. But I would like to go beyond the specific tools and interventions here to really reflect on the systems that support delivery of this intervention. And this consideration around the systems and the services is also, particularly important when we think about, strategies to help specific population of vulnerable children and displaced children, because these populations are too often neglected and underserved, if not excluded by services. And this is where the new service guidance for the mental health of children and young people comes in. WHO and UNICEF developed this document for policymakers and others responsible for mental health services for children and young people. In fact, we know that there are massive gaps in mental health services for children and adolescents. These services are often non-existent, and where they do exist, they are often fragmented, inequitable, or inappropriate for their developmental needs. When we reflect on the WHO mental health data, Atlas data, we consistently, see a really scarcity of mental health professionals, particularly in low and middle income countries. Yet, there are multiple benefits of investing in the mental health of young people. We know that investing in mental health of young people improves educational outcomes, and the economic case also stands out. A package of adolescent mental health interventions can yield a 23.6-fold return on investment over 80 years. So the service guidance wanted to show that there is no single best model for organizing mental health care, but rather that countries can start to work with what they have. And most importantly, that every country can proactively take steps to expand, develop, and reorganize services for children and young people. The focus of this guidance document is on equipping stakeholders with practical insights and tools to strengthen services, and specifically to strengthen community-based services, that is, any service provided outside of a psychiatric hospital. The approach outlined in the guidance is broadly based on two key principles. The first is about community-based mental health services for young people should be arranged in a network of interconnected services. And these slides really show the network of community-based interconnected services, and with a focus on really reflecting on the different opportunities of integrating services into the existing network of services, as well as opportunity to expand the network to build more opportunities and access to mental health care within communities. This approach means that different service providers, including schools, primary health care, non-government organizations, and civil society organizations, collaborate to provide mental health services. The second key principle is that mental health services are delivered through a trained, supported, and diverse workforce that consists of mental health professionals, as well as non-specialist providers and volunteers. Zooming in a bit further on the concept of the network of interconnected services, we specifically think of mental health services for young people in terms of services within the general health care, services within community-based services, and then beyond the health sector. Within each of these groupings, there are a number of different approaches that can be adapted for use in different settings. And this guidance document provides implementation examples for each of these different grouping or models of organizing services from around the world. The variety of potential approaches to service strengthening is well illustrated in the primary healthcare context. Primary healthcare services are foundational to the provision of mental health care for young people. They usually rely on trained and supervised non-specialist workers. Yet the way the child mental health care is delivered in primary healthcare setting can vary significantly. And these approaches can include, for instance, co-location, where specialists are based at the primary healthcare level and provide care directly. Or, we can have a consultation model where specialists are on call to help and advise primary healthcare workers. Or, we can have a collaborative care model. And in this case, a team-based approach, where a care coordinator supports both specialists and non-specialists to provide care for individual users. Looking into examples of service design option for community mental health services, we find a number of examples, including the Netherlands flexible assertive community treatment. And these examples of community-based mental health services demonstrate how comprehensive care can be organized to meet the needs of young people with severe and/or emerging mental health conditions within communities. We know that community mental health services provide an accessible, person-centered, and culturally sensitive alternative to hospital-based care. Crisis services that support children and young people experiencing acute mental health needs are a critical component of community-based mental health care. This example from France was developed in response to a significant increase in children and young people requiring crisis mental health care during the COVID-19 pandemic. One-stop services have been developed in direct response to poor linkages between services for young people. The model was developed in Australia and has expanded and been adapted to other settings, including Denmark, where the centers are run almost entirely by trained volunteers. In Denmark, Headspace offers, among other services for youth, free confidential counseling and support for young people's mental health. We have also some good practice examples specific to the humanitarian context. In Haiti, for example, a model was developed to enhance capacity for nurse specialists to deliver a wide array of support services to young people in underserved regions. Primary healthcare workers share mental health tasks with specialists after receiving culturally adapted mental health training. Community health workers and teachers are also trained to recognize mental health conditions using a culturally relevant screening tool and provide basic support. The model demonstrated feasibility in resource-constrained humanitarian contexts. Another example from Sierra Leone, a group counseling program was delivered by lay counselors and integrated into a program that taught unemployed and out-of-school young people employment and entrepreneurship skills. This program has been scaled up nationwide. Finally, the guidance describe, beyond the models of implementation of services, also some important domains for standards of care. That is, what we can consider as acceptable and adequate quality of mental health care for young people. And in defining these domains, there is specific attention to the requirements and preferences based on the developmental stage and also the requirements of different populations of children and young people. The right-based approach underscores the entitlement of displaced young people to mental health support, protection from harm, and meaningful participation. The principle of integration and collaboration across sectors, such as social protection and education, is also particularly relevant in crisis situations. I'd like to share with the last few slides also some recent experience with supporting system strengthening in countries. And this was done in the context of the implementation of UNICEF WHO Joint Program on the mental health and psychosocial well-being and development of children and adolescents. The program has been implemented in 13 countries over the past 3 years, and it aims to accelerate action for some sustainable change. And again, the focus is about improving environments for children and young people's mental health and improving access to quality services. You see in this slide the list of the 13 countries that have been the participating countries for this first phase of the joint program. So in countries where the joint program has been implemented, the approach involved inviting some key country-level stakeholders to consider gaps as well as priorities when thinking about 4 different areas of action. And you see in this slide these areas of action. That includes the area about strengthening leadership, governance, advocacy, the area about promotion prevention. Third is strengthening service. And the last one is about strengthening information systems and evidence and research. So then the approach involved, allocating seed financial contributions that were invested in action to establish, first of all, the foundations for child, adolescent mental health programming. Because in many contexts, these foundations around these structures that could support programming for child, adolescent mental health were not in place, or were, not meeting certain requirements of including the perspective of young people or including different sectors. And so some seed financial contribution was invested in making sure that this mechanism for intersectorial coordination with engagement of local partners, including youth, were in place. And then, this mechanism were also, the prerequisite for countries to conduct some situation analysis and define, based on the context, some joint work plans that really articulated what were specific opportunities for introducing catalytic changes that had the potential to make impact in terms of improving environment and services for young people's mental health. And then the joint program supported the implementation of these catalytic actions through enhancement or expansion of local solutions and or adaptation and implementation of WHO and UNICEF tools or other open access evidence-based tools available to countries. Côte d'Ivoire is one of the 13 countries that were engaged in the context of the joint program implementation. The focus for Côte d'Ivoire, as identified by country stakeholders, was strengthening planning and strengthening the workforce capacity for child and adolescent mental health and psychosocial well-being and development. The human resource level for child and adolescent mental health is limited in Sierra Leone. According to WHO mental health Atlas data, there are 0.03 child and adolescent psychiatrists per 100,000 population and 0.28 mental health workers. In response to the Central Sahel crisis and influx of refugees from Burkina Faso into northern Côte d'Ivoire, there was also a specific approach that was designed and implemented by the government of Côte d'Ivoire. And this involved establishing a roster of social workers and training them in mental health. These social workers were then deployed to emergencies affected areas, providing services to both people living in emergency camps as well as host communities. So Côte d'Ivoire is one of the examples of implementation of tailored strategies to reach displaced population and vulnerable populations with dedicated strength and capacity for mental health promotion and protection for young people. To date, across all joint program countries, so 13 countries, WHO, UNICEF have been able to directly reach 7 million children, adolescents and caregivers, but this is a drop in the ocean. So I'd like to end my presentation with again an invite for us all to strengthen our collaborative capacity and reach many more children, adolescents and families in need. Thank you very much.
Thank you, Chiara. Now we're going to have a slightly different presentation. It's a live presentation, but it comes all the way from Hawaii, where we will be getting a presentation by Professor Anthony Guerrero, who is the chairman of the World Psychiatric Association Child Adolescent Psychiatry section, and he will be sharing a talk on finding opportunities globally to care for youth vulnerable to displacement.
Hello.
Hello.
Hello, Dr. Fung. Can you all see my screen okay?
We can't see your presentation mode.
Okay.
There you go.
Well, thank you so much for the opportunity to present today. And I really do want to thank everyone who made today's wonderful event possible. And I wanted to thank Dr. Fung for the gracious introduction, and to the Turkish Association for making all of this possible. So I want to extend on behalf of the World Psychiatric Association Child and Adolescent Psychiatry section our warmest greetings to all of you, and best wishes for a happy World Infant, Child and Adolescent Mental Health Day. So the title of my talk is Finding Opportunities Globally to Care for Youth Vulnerable to Displacement. And again, I reiterate my greetings from where I am in the world, which is in the city of Honolulu in Hawaii in the United States. I don't have any disclosures for today. My objectives are to discuss the injustice of disproportionate homelessness affecting Indigenous and other disenfranchised youth, to discuss the factors associated with homelessness in Hawaii, to highlight the likely and growing role of climate change and displacement affecting youth in this world region, and to illustrate the point that wherever you may go in the world, you will find children vulnerable to homelessness and associated adversities and disparities, as well as climate change. And overall, I hope to increase our awareness of displacement among youth and to help us to hardwire our practices so that we may appropriately identify and address youth who have been affected by displacement anywhere they may be in this world. I'm greeting you from Hawaii, which is about 8,330 miles or 13,423 kilometers away. And Hawaii is an island state and located in the middle of the Pacific. And I wanted to offer my land acknowledgement, as we commonly do when we learn and we make presentations. You know, we recognize the Indigenous place as well as the Indigenous people that that live in these lands. And I asked ChatGPT a few days ago, what are all of the similarities between the part of the world where I'm sitting in and the part of the world where you're all sitting in? And you know, there were a few interesting themes that came up, you know, including tourism, physical beauty, rich cultural heritage, diverse landscapes, and a strong sense of community. So, you know, I think with these common elements in our cultures, I wanted to just lay that as a foundation for the unity that I think we're all feeling this afternoon or this morning in addressing this important topic of child and adolescent mental health. These are some images from Hawaii. We're the only part of the US where you will find a royal palace, and the geographic diversity is really wonderful as well, with canyons as well as mountain lakes and a snow-capped mountain, at least for parts of the year, and a medical school that is among the top 3 most beautiful in the country. And what I'm about to tell you is an important story of the Indigenous people that live in Hawaii. These islands were settled in probably the past millennium by Polynesian navigators from other islands in the Pacific Ocean. There were probably about 800,000 Indigenous Hawaiians prior to regular Western contact in the 1700s. And, you know, for hundreds of years, there was regular voyaging and cultural connections between the Indigenous people of Hawaii and other parts of the Pacific. And, you know, the islands and the island nation was unfortunately over the government of the Hawaiian Islands was unfortunately overthrown, and the nation was annexed illegally by the United States, and the United States subsequently apologized in 1993 for this illegal overthrow and annexation. And there's a lot of very interesting other history that we can learn about how the islands were settled and the cultural connections between our islands and the other people within the Pacific. So in looking at opportunities to identify and help youth who are displaced, I wanted to share one very important statistic that are known to many of us in healthcare here in Hawaii. And it's that there's significant overrepresentation of Native Hawaiians and Pacific Islanders in the homeless population of Hawaii. And this data specifically covers the island of Oahu, where the city of Honolulu is located. So, as you'll see here, even though Native Hawaiians and other Pacific Islanders may represent about 10% of the population, um, they represent about 41% of the homeless population or um, population in transition here in Hawaii. So, that in and of itself should be a very alarming cause of concern and a call for all of us to try to see what can be done to address this significant disparity and to care for, the youth and the families affected by, homelessness and being in transition. Yes, there are children and families represented in this homeless population on the island of Oahu. And, no matter what the efforts have been these past several years to provide better housing for youth and their families, there still remains significant numbers of unsheltered youth and unsheltered families here in what is otherwise a fairly modern and urban city that is known for attracting tourism and um, um, being very welcoming in other ways. So I think one important foundation in being able to identify youth and families affected by displacement is to really pay attention to where the disparities are among the mental health of children, adults, and families in this world. So we have to be aware that disparities are born from differential exposures to poverty, trauma, discrimination, barriers to accessing mental health care, and acculturative stress. So whenever you see these factors all together, you may encounter youth who will be at risk for displacement. And um, um, the additional note here is that these disparities, including the risks for incarceration, suicidal behavior, and displacement, significantly impact Indigenous populations, immigrant populations, and other disadvantaged populations throughout the world. Okay, and if you go back a further layer upstream, you're going to find that there are many different mechanisms that lead to these mental health disparities. Some of these disparities are born from biological factors, including nutritional insecurity, epigenetic impacts of historical trauma. Many of these factors can include acculturative stresses faced by immigrant and indigenous youth and, trauma from other adversities that arise in the context of poverty. There's other kinds of factors that cause people to be marginalized in other ways, especially when it comes to healthcare delivery and delivery of other social services. And it's very important to note that poverty in and of itself may increase stress, lower self-worth, and limit opportunities for education and other developmentally appropriate activities, such that there can be a cycle or a perpetuation of poverty and a continuation of this risk for displacement. So in looking at some of the characteristics of the homeless and unsheltered individuals here in Hawaii, there's a lot of factors that have been uncovered. But, one of the significant ones that has come up in the past couple of years is the effects of climate and environmental change, and more specifically, on one of the islands, a set of wildfires that were very devastating and that took many by surprise. And even though it only represented a small proportion of the homeless and unsheltered individuals in Hawaii. It's potentially one that we really need to pay attention to when looking at some of the causes of displacement on a global level. Just to go over the others, I mean, people who have been marginalized, including sexual and gender minorities, those with mental illness, those with disabilities, those with substance use disorders, those suffering from domestic violence. These are all other risk factors for being homeless and unsheltered. So, um, I did want to just pay a solemn remembrance to the individuals who lived in the city of Lahaina in Hawaii on the island of Maui and who lost their lives or had their lives significantly affected by the wildfires on August the 8th, 2023. And, with this, I also wanted to pay tribute to all those in the world who have, lost their lives to um, displacement, who have lost their lives or who have faced displacement related to climate change and other environmental disasters. So this is very interesting study and all of the things um, that we do either by omission or commission that can result in such horrible tragedies and loss of life. It's very fitting that the town of Lahaina, it translates into a cruel sun in the Hawaiian language. And there was a long history of, capitalistic farming practices that diverted water from Lahaina and other native Hawaiian communities to plantation-controlled lands and luxury estates. And, as the economy shifted from farming to tourism, plantation lands were overgrown by invasive, unkept, and highly flammable grasses. And, um, you know, it's very sobering to think that all of these human-made activities, all of these shortcomings in how we take care of the land can result in loss of life, and for our purposes, things that can significantly impact the mental health of kids and youth and families throughout the world. So, our job in addressing youth and other people's displacement is to really pay attention to, how we can mitigate all of the causes, whether it's from environmental change, from war, and um, um, pretty much everything else that we may not traditionally think of as being in our purview as mental health providers, but that really are when it comes to what to advocate for. Okay, so um, several of us feel strongly that when we as child and adolescent mental health providers work with kids, we really should be asking certain questions. We should be asking about their current living situation. We should be asking about recent or anticipated moves and the reasons for relocation. We should ask about how food, water, and other life essentials are obtained, and we should also ask about family traditions impacted by the changing environment. If we don't ask these questions, we may never realize um, who is facing displacement and what opportunities we may have to better address their mental health. Just reflecting on, some of the ways that environmental change specifically affects this world region, in island communities, rising sea levels can destroy crops and traditional farming practices. It can inundate places where, there's cemeteries and, other culturally significant places. Um, and I do want to highlight that in this region of the world, there is a lot of urgency in the impact of climate change and the likelihood that we will be seeing more and more displaced people. When you have rising ocean levels, when you have more devastating storms. Um, And related to this are all of the other things that can affect human health, such as undernutrition, infectious disease, and premature death. And once again, I really do think that it's it's an unacceptable injustice and a tragedy that there are um, such disparities in who is affected by homelessness, and the fact that people are likely to become homeless in their own indigenous land. Um, and I say this not just for the part of the world where I'm very blessed to live, but in other parts of the world where this can occur. Um, so I think as mental health providers, we really do need to care for our people as well as the planet that sustains all of us. We do need to do whatever we can to be voices against armed conflict and other things that cause displacement. Um, and I think if we look at all of the stresses that kids face and how mental illness evolves throughout development, we have opportunities to really try to mitigate these risks so that infants, children, and adolescents can grow up healthier. And part of this is really paying attention to all of the different stresses. And one of the stresses that we are focusing on today and uniting on as all of our organizations is, the stress of displacement and all of the downstream impacts that it can have. And as I mentioned a few moments ago, I do think that all of these are very much interconnected. If we take better care of our planet and our environment, if we pay attention to human conditions, if we're acutely sensitive to disparities in how people's living conditions are, I do think that we can do a lot to, improve health and even do things like, prevent, future pandemics if we look at it as connected to, the well-being of our physical environment. And I just wanted to close by mentioning that, it was not too long ago, within the last um, several decades that, we maintained an isolation colony on one of our islands for patients afflicted by Hansen's disease. And, as we know, Hansen's disease is not the most transmissible disease, and it's also very much treatable by, modern medications, but yet it's one of the most highly stigmatized illnesses that really caused forced displacement, forced isolation, and, that was really a scourge on, indigenous populations and other folks who were disadvantaged. And, these are images of, you know, what um, what happened in the colony for patients and individuals with Hansen's disease in Hawaii. Um, and we think that we all went past that, when the last patient was admitted there in the late 1960s, and with the deinstitutionalization of care for patients with Hansen's disease and other chronic illnesses. We think that we've gotten past that, but unfortunately, I mean, when we look at mental illnesses, we are still stigmatizing them, and we are still um, um, isolating people and not doing things early enough in their life so that they don't have to face the trauma, the displacement, the isolation from their communities and their families. So, um, I just wanted to put out there that, our illnesses are the modern day equivalents, if you will, to things that once led to isolation and stigmatization. And so I think we have an opportunity to spread the word and, really advocate for improved access and improved awareness early in life. So with that, I just wanted to share some of my references. I am very happy to be in touch and to, continue to join in the dialogue on how we can all optimally take care of infants, children, and adolescents in the world, and to especially pay attention to all of these youth and their families affected by displacement. So thank you very much. Mahalo nui loa.
We should quickly get into position. Okay, I will stand here. Yeah, would that be good? Yeah, I think. Yeah. Okay, so maybe as a start, a couple of clarification questions. One is from Zuli Vok. I don't know if this is a male, but well, Zuli has left. But if Campbell, you could answer that question. Could any of the panelists elaborate more? And I think it's for you to talk about the expressive creative mimesis, which you mentioned in your speech, related to the baby and parent interaction. Are there curriculums, manuals, or trainings available to enhance parental response to babies, especially during stressful situations like displacement?
Well, thank you very much for what sounded like a simple question to becoming a quite complicated one. There are a lot of different interventions that have been developed. In my career in infant mental health, we went from maybe 3 or 4 different modalities to now 50 or 60 different modalities with varying degrees of evaluation and evidence-based. But there's certainly a really broad range of interventions. The Anna Freud Centre did a review of evidence-based interventions and that was published in 2023. So that sort of is available. Colin Trevathan was always a bit cheeky, and I think his terminology was, you might say, unnecessarily complicated, but I think what he was trying to say is that babies, infants, toddlers can perceive and give meaning to and remember things that are happening between them and important people, and use those memories to develop their own ways of communicating and playing and being with other people. So there's a circular process that begins really at birth that leads on to our capacity to interact and play with others.
Thank you, Campbell. And maybe I could point this question to Tony. It's from Liz Marie. It says, I am passionate. Oops, what has happened to the question?
Oh, sorry. I think I may have answered it, but...
okay, you answered it.
Yeah, I didn't realize it would have disappeared.
It would be good for the audience online to hear, yeah.
It was a question on,
go ahead.
On interest in caring for the environment and what can we do as as professionals, and there's actually an emerging set of resources for mental health providers and psychiatrists that are interested in climate. There's the Climate Psychiatry Alliance, and there's various papers and even reviews on the role that psychiatrists can play in addressing climate change. It's not just in our practice where we see patients affected by climate change, but it's also cultivating our own responsibility as mental health providers and in mitigating the harmful effects that anything in our practice can have. So yeah, sorry if I deleted the question, but hopefully that's a helpful answer.
Yeah, and he's probably typed in an answer so you can check it. I just, at this point, can I ask that someone adjust the camera as the speakers, because it's only pointed at me and people want to see the rest of the panel here. So as they answer, you could move the camera a little bit to point at the person. Okay, here's a question. It's from me. I'd like to ask Matthew, tell us a little bit about cortisol. I said we didn't have time to talk about it, but it'd be interesting to hear this. After all, we do know that that risks of displacement and other stresses can affect neurophysiologically many of the children. What are the effects of studies? I mean, we have evidence from abuse, but displacement itself, is there evidence of neurophysiological changes that are important, or should we be looking elsewhere?
Well, a number of studies have been done in recent years looking in particular at cortisol and the effect of cortisol on cognitive and other aspects of function. Actually, cortisol is a very complicated hormone because how cortisol changes with stress relates to the nature of the stress and its duration in particular. So in acute stress, you may get elevated cortisol, plus with chronic stress, you may get habituation. So in fact, cortisol levels may not be very elevated. It has been established over the refugees that because of the nature of the events, in other words, often they've had a settled, calm lifestyle prior to war and organised violence, and then there's been sudden stress, that actually they do have a very elevated cortisol. And the implications of that are in particular on mood, and then, as I said, the epigenetic changes, which in particular be manifest in the brain, affecting memory. And then these changes actually may be transmitted to the next generation. And there have been studies looking at why the children of, say, Holocaust survivors, people who experienced the Holocaust during Nazi Germany, during the occupation in Europe, their offspring may have elevated rates of PTSD. And investigators started to look at the mechanisms, including epigenetic changes. This is a methylation of DNA. And it's thought that actually that could be a very important mechanism as to why the offspring of people exposed to war and disasters have elevated rates of PTSD. Previously, the explanation was always given in terms of the family narrative of war exposure, but now we have elucidation of an additional mechanism.
Thanks, Matthew. And the next question is from an anonymous attendee, but maybe Fusun could take the question. How would a community counseling service work? Since infants, toddlers, children, adolescents are a vulnerable group to work with, how can lay counselors work with them while providing a service that will not be more harmful to the vulnerable target group? And besides Fusun, anyone else can sort of chip in. How are these programs monitored, or I presume credentialed or regulated? Difficult question.
Yara has already made a good summary of that.
Yeah.
But for adolescents, let me give an example we had in Turkey. That was some years ago. We established an adolescent mental health centers at the primary health care level. That was part of a project of the Ministry of Health with the UNICEF, actually. And what we did, till that time there was no, mentioning of adolescent mental health care separately from child and adolescent services, so as was infant care. So what we did, we had a place just separated only for the entrance of adolescents and their families, just besides the primary health care units of the health system. So there was the physical primary health care unit, and that was what it was called in Turkey. We don't have, like GP system. We didn't have at that time. We now have a family doctor system in the country, but at that time there wasn't any family doctor system, but primary health care system for everybody. And then we had this adolescent mental health centers. Actually, it was called Adolescent Health Center, but mainly working as the mental health center. And we get them affiliated with a tertiary adolescent center The reason was that tertiary, because at the time, again, we didn't have any secondary level adolescent mental health services. So it was only in some of the university departments that the adolescent health and mental health is considered. So what they did, they allocated a nurse, a physician, and a clinical psychologist and a social worker to work in those centers. And we trained them for adolescent health and adolescent mental health for some time. And after completing these training courses, they started working there. But, you know, when they thought that there is a problem to be, you know, treated, they will directly call the person in charge in the university department, and we would make an appointment for the teen to be evaluated. On the other hand, the social worker and the nurse was also doing the field work there. And we developed several, you know, questionnaires to scan through some very frequently seen psychological problems or psychiatric disorders for scanning purposes. And the results of the questionnaires were being evaluated at the university departments again. And we plan to make some intervention programs for those under risk individuals and families. And we had some groups running, and so we also had psychodrama groups for adolescents under risk. And also we did that at the time when we had the big earthquake in the Marmara region in 1990. Also for teenagers and older adolescents too, psychodrama group interventions for preventive purposes, and that worked really well. I mean, the results of which were really fine. And these adolescent mental health services were spread all over the country, not in every city, but almost one in every region, and we're working quite well. But you know, policy doesn't go along with the medical results, unfortunately, in some countries, as it is in Turkey. So the politics change, and new people coming in charge of mental health system, unfortunately, didn't even consider the results of the improvements in the system. They just canceled the system, and all those mental health centers were closed.
I see.
So this is a bad example, but actually it was a good example.
Because it worked at that time, yeah.
The intervention results were good,
yeah.
But the ending, the sustainability, that's usually the issue, you know, with the system works. The implemented programs are not, cannot be sustained because of the financial reasons as well.
No, I was just kind of thinking about what Matthew talked about, the tiered care model, which I will speak to, because I think tiered care models are linked to step care models, and they do work, and they probably provide a good sustainable model if countries will take them on at breath and death. So the key issue really, as you said, is sustainability and how to sort of create an ecosystem of support. There is a lot of things that healthcare systems or mental health care systems cannot do on its own. And I think I heard Campbell talk about this interfacing with all the health, within health and outside of health, which is quite critical in doing something like this. And reflecting a little bit on one of the questions, which says, hopefully this Congress and all the organizations represented here send the to the press, governments, some of these concerns, particularly around, of course, this idea of displacement around conflicts around wars and climate change and inequities. We should give our voice to all the children in despair. Thank you for standing up for young people. I think that's an important reminder to us. I'm going to do the last question to Campbell, give you that last question, but also ask you, each one of you, to think of some kind of final wrap-up note as we close, because time is a little short. But before I do that, I see some people sitting here and they spend the whole afternoon with us. Would you like to ask any questions, the live audience here? You have a chance to do that, because I forgot to ask you guys, and I was trying to answer questions on this Q&A. And if you do have a question, please feel free to raise your hand. No? Okay, then I will ask Campbell his question from, it's from Beta Joanna Kozilek. Is there any known program that monitors and supports women experiencing symptoms of mental disorders during pregnancy and perinatal period? And can you share your own reflection on the topic, presumably around displacement as well?
Yes, there are a large number of programs being developed and have been developed for women with significant mental illness during pregnancy, through childbirth and the early years of the infant's life, and together. And it's actually a big area of discussion at the moment. In Australia, for example, we've now planning for a conference in September, which will be a joint conference between Infant Mental Health Association and the Perinatal Mental Health Association, called the Marseille Society. So we've done that a number of times. We've worked with infant perspective and with services that have a more traditional adult perspective. And we're seeing more and more overlap and blending of the work between infant work and perinatal mental health work. And there's lots of examples of actual programs. And one example would be one that's very popular, Circle of Security, which, as it was originally designed, was working with young women with major psychosocial and mental health difficulties, often young women who might have had a diagnosis of borderline PD, and they were came to the attention of this service, and they were working as a group. So there was sort of peer work as well as leadership from the treating team. A key part of that original Circle of Security was a video. Each of the mother-infant couples would take a video of an interaction between themselves and their baby, and they'd share it with the big group of up to 12 or more, not so many, up to 8 or so mother-infant dyads, and they would talk about it. So they would have their peers comment on what they saw in the interaction. Gee, you look pretty sad there, but I noticed that when your baby smiled, you were able to smile back. So they would generally try and pick up the positive interactions and share that with them in this safe therapeutic group. So that's just one example of the overlap between infant and parent mental health, but there are many others.
And any final comments? I mean, I'm going to go through the rest of it.
Well, I think that the idea of interventions for children, infants, adolescents, and their parents, which is the other key component of the discussion, in the context, even for adolescents and their parents, in the context of displacement, is a really important one. But, and I think the other thing is that one shouldn't feel overwhelmed by the massive size of it, although I do, as you think about the millions of children who are in the context of displacement as a result of war or natural disaster, mainly through war and internal conflict. But we shouldn't be dissuaded from trying to implement interventions. For example, like the one I mentioned in Cox's Bazar with Rohingya refugees, where you can engage those of the community who are also displaced to use their intrinsic skills with support to support their peers, their other families and the other children and adolescents. So don't feel overwhelmed, but there we go.
And thank you, Campbell. And Fusud, any last comments?
I would like to say that I think it will be very important, as mentioned in all policy programs and as the WHO division chair has also mentioned, that we need to think in terms of age levels for all the prevention, promotion and intervention programs. So for my part of this meeting, I would like to say we need to, advocate for adolescent mental health in a separate way. Of course, along with all child and adolescent mental health, but adolescence has separate and distinct needs compared to other age groups. And it will be very good to listen and to look for those needs and for all adolescents, not only for the displaced ones, because the developmental needs has the priority at all levels and for all groups of adolescents. So we need to be advocating for that, I guess.
Yeah, absolutely. Then, and that's why this day that we are commemorating, we're thinking about commemorating is the right word, World Infant, Child, Adolescent. Yeah, we need to look at the various stages. I'm going to go to Tony over there in Hawaii. Do you have any final words or comments? Apparently, you are the only one that's been seen. I hope that they've corrected that. Yeah. Oh, now we can't hear you at all.
Go ahead,
yeah.
Yeah, I just wanted to, say thank you so much, Daniel, for, your vision in organizing this symposium and for, being the driving force behind World Infant, Child, and Adolescent Mental Health Day for, the past few years. And, I really do think that when we have forums like this, we see so much in common that we all have. And, I think hopefully many of us can emerge with a lot of optimism that, when you're looking at infant, child, and adolescent mental health, there really are so many opportunities to light a candle in the face of darkness, so to speak, when, facing all of the adversities in the world. So, thank you very much to all of you for the inspiration and, just for the chance to begin, new dialogue on these really critically important areas.
Thank you, Tony. I hope that light to the darkness obviously doesn't set the wrong fires, but the right ones. And finally, Matthew, I'm going to take the opportunity as chair to close. So, Matthew,
okay, thank you very much. Okay, so I'm going to confine my comments to children and adolescents impacted by war and organised violence. I'm going to divide this into two parts. Firstly, research. I think what we need is far more sophisticated models, cumulative risk factor models, to understand what is the nature of the interaction between these processes that result in poor outcomes in terms of psychopathology, and conversely, better outcomes, in other words, the question of resilience. And in relation to the clinical treatment delivery, my comment is we need to have a move towards a much more personalized, what you might call precision medicine approaches, which are going to need to incorporate digital applications. So we will be able to provide services to far more people, taking into account their own individual needs, which could, of course, be assessed digitally, not only interpersonally, because the scale of the problem that we're facing. unless we look at it in terms of scale, I think we're going to be stuck with some old models when, in fact, many of the displaced people we use have, in fact, very high levels of usage of mobile phones. So we need to think to integrate these models into new applications alongside the kind of services we've already outlined for those who are much more impaired, who do need interpersonal and person-based treatment delivery.
Yep, thanks, Matthew. In fact, you answered the last question, which was directed at you about how low-income, middle-income countries, can manage this with the support systems that, for example, in UK you had developed. And I think it's important. I'm just going to close with two things. There are two areas which I think, alongside Matthew's point about lack of research, is this whole area of cultural shift that we are experiencing across the world. And of course, I take the example from Singapore, a cosmopolitan city. We have an increasing number of young people losing that meaning and purpose that Fusun talks about. And I reckon that spirituality, an area that's very not enough research is being done, needs to be looked at, because it provides meaning and purpose for the young. The second point is, of course, about social media. Its growth over the, we actually have about 162 handphones in Singapore when we have a population of about 162 handphones per 100 person. It's almost twice the number of handphones per person, as opposed to the, other means of communicating. And social media particularly, I think, are quite powerful tools which perhaps used for good would be more important than what is happening in terms of its impact on young people's mental health. So those are two areas I thought was important for us to focus, do research, and try to be evidence-based. Our evidence base is only useful when we deliver it to the population. It is not useful if it sits in the universities of the world. So I think that's the other piece, the last piece, about how we collaborate, why we have all these associations coming together. We may need more. We need to bring ourselves before the press, governments, and other associations to push this message that mental health is critical for the future of the world, in fact. So with that, I want to thank everyone for coming, those online. I don't know the actual numbers. I saw about 100 over at some stage. And I thank you all for sharing this today. Today is not the actual World Infant Child Adolescent Mental Health Day. That's the 23rd of April. So next year, we will try again to have a physical meeting and a hybrid conference. So until we meet again, continue to do your good work, everyone, whether you are anywhere in the world, as well as whether it's in the morning, the afternoon, or at night. Thank you very much. And thank you to our panelists for spending time with us, virtually and in person. With that, thank you and good evening from Kusadasi in Turkey. Thank you very much.